Hello and Assalamu alaikum. We are here again with the kidney section of your pathology, and welcome to this class of special pathology. Please let me know if there are things you do not understand, because we are now going from difficult to the easier things to read. This is cystic diseases of the kidney. Until now, almost half the class has joined, nearly half the class. And for the rest, I just wish them good luck. They can miss whatever they like to miss. So, as the name suggests, kidney has got cyst in them. And if there are cysts, it means you're losing the functional component of the kidney. It means that either there's pressure on the nephrons or they are lost. So, where do the cysts form actually? From where do the cysts come? And what is cyst? It is just an outpouching of uh, cyst is just an outpouching of a normal tubular structure that will give you a balloon-like or cylindrical outpouching that will be lined by the same epithelium as the organ, and it will secrete something, no matter it is blood or it is mucus or it is serous fluid. So it has to be filled up by something whenever there is a cyst in the body. Well, I must praise one of my students, Wasim. He is always very early to join, and I'm thankful and grateful to him for waiting for the class. Right. So, cystic disease of the kidney is first you must know the classification. If you don't know the classification of the disease, it will be difficult to understand and memorize individual cystic diseases. So please, I'll just open the chat box. If there is a problem, you could talk in the chat box or you could write things in the chat box. It is easier that way. So multicystic renal dysplasia. We have done this one before, but I'll just review quickly the diseases that were done before, and I'll try to make you understand in detail or discuss in detail the diseases we did not study before. So multicystic renal dysplasia is the only dysplasia we did study last time. Then comes polycystic kidney disease. It could be dominant or recessive. If it is dominant, it is the adult type of polycystic kidney disease, and in children, it is the recessive type of polycystic kidney disease. So adults have dominant type and children have recessive type of polycystic kidney disease. And as the name suggests, there are several cysts everywhere. Medullary cystic kidney disease, these are in the medulla alone. And there are two types, medullary sponge kidney, which is autosomal dominant, and nephrotheusis. Nephrotheusis is autosomal recessive. They have, both of them have defects in cilia, but there are, with a few differences, they have similar features, right? With a few differences, they have similar features. And because they have similar features, your book, Robbins, mentioned both the diseases together. And then comes the acquired diseases. Acquired, we have dialysis associated. This is the only acquired disease that we have. Then we have a simple renal cyst. Simple renal cyst may be discovered incidentally. Then renal cyst in hereditary malformations, glomerulocystic diseases, and extraparenchymal renal cyst, which is pilocalcidial cyst and hilar lymphangiatic cyst. Some of the cystic diseases are in the classification. You must know them by name, but they are not included in the description in your book, since there is a lot of things to read, understand, and memorize. So I would like to concentrate on your book and your recommended course from UHS. All of you can download, since you are taking lectures on the computer. I understand that you do have a computer. So download your course or your schedule from the UHS website, and you should undergo or read the topics given there. We teach you the same topics. We leave the topics there that are not given in this UHS course because they're not supposed to appear in your exam. All right. So the next, this is how the cyst forms. This is the glomerulus and the Bowman's capsule. Usually, the Bowman's capsule is spared. However, in some cases, it may get involved as well. But these renal tubules get involved in cyst formation, and those could be in the medulla, interstitium, collecting duct. Any place in the tubule can get involved in the cyst formation. It is quite rare for the Bowman's capsule to get involved in the cyst formation. Here is the lining epithelium of the cyst. So it is the same from the area from where it arises. If it arises from the collecting ducts, there is a possibility that it will include transitional epithelium as well. Otherwise, if it is from another side of the duct, it may include columnar or cuboidal epithelium, right? So there is decreased apoptosis and increased proliferation of the cells to form a cyst here. It is just an outpouching of the normal epithelial tubule, renal tubule. So multicystic renal dysplasia, as the name suggests, it is lot of cysts there in the kidney, lot of cysts are there in the kidney, and there is dysplasia, which means you can find all sorts of tissue. So it is a sporadic disorder. Abnormality is in the metanephric differentiation and persistence in the kidney of abnormal structures like cartilage, undifferentiated mesenchyme, which means undifferentiated tissue that is formed by the mesenchyme, which can be bones, cartilage, or any other tissue, immature collecting tubules, and by the abnormal lobular organization may be there. There are islands of cartilage. Blood vessels are there, islands of cartilage. This is a fibrous tissue. So you may see a whole lot of tissue along with the normal renal tubules, and you will see renal cyst indefinitely to diagnose cystic renal disease. And this is dysplastic cystic renal disease, occasional islands in the cartilage. So you can see compressed stroma or compressed epithelium of the collecting system, collecting tubules, right? Presence of islands of undifferentiated mesenchyme, cartilage, and it could be immature collecting ducts. You can even see immature collecting ducts. So they're mature and immature collecting ducts. You can see here compressed epithelium, right? This area is compressed epithelium, and this area has got columnar epithelium. And there is dysplasia like cartilage. You can see chondrocytes, islands of chondrocytes, and you can see other tissues as well. Numerous blood vessels that can be in the phases of maturation. So this is the cyst, and we have taken cross section from the cyst or from here. Cyst will only show you this thing, compressed epithelium, right? This structure or the cyst will show you compressed epithelium. And this is the area, renal area, kidney, from which you will see all sorts of tissues. Of course, there will be obstruction. Sometimes this pathology involves only a portion of the kidney. It may not involve the whole kidney. It may involve the portion of the kidney. So some normal function may be preserved, but if the renal cyst causes obstruction, utropelvic obstruction, you'll have the same symptoms as any obstruction disease gets. Unilateral agenesis or atresia, right? So it will be unilateral atresia if the kidney is not allowed to function because of obstruction. Other abnormalities of lower urinary tract may appear, which can be unilateral or bilateral, but cyst is, you have to see cyst or you have to have cyst to diagnose cystic dysplasia. If there is only dysplasia, you don't diagnose cystic dysplasia of the kidney. So you have to have cyst to diagnose this disease. Right. Largest longitudinal diameter is 14 centimeter, whereas the normal kidney is only 6 centimeter. So it grows in size. It becomes big kidney and nearly double or more than double the size. Now we come to autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease appears in adulthood, has a hereditary disorder. It is a hereditary disorder. It has multiple expanding cysts of both the kidneys that ultimately destroy the renal parenchyma and cause renal failure. It destroys the parenchyma, which means that these cysts are located in the cortex of the kidney, right? Expanding cysts, multiple expanding cysts are located in the cortex of the kidney, and they eventually destroy the renal parenchyma. If the cortex is destroyed, the functional unit of the kidney is destroyed, then what is the result? The result is renal failure. And what is abnormal is protein polycystin. What is abnormal is the protein polycystin, polycystin type 2. Polycystin type 2. Right. So this is what polycystic kidney looks like externally. So if you have to describe gross appearance, you will say it's a mahogany brown kidney with a lot of external cyst, smooth kidney, but lot of external cysts that are variable in size. You could just tell the size of the largest or measure the size of the largest cyst and then the smallest cyst that are variable in size. The large cyst measures so and so, and you can see large cyst of the kidney. In this, there is altered tubular function and differentiation. Because of altered differentiation, you cannot expect normal function from such tubules that have such large cysts. And there is a lot of cell proliferation, decreased cell apoptosis that causes the cyst. So basal level of apoptosis, which means apoptosis has decreased, cell proliferation has increased, and there is interaction with the extracellular matrix. Secretory function of epithelia becomes abnormal. Kidneys are large and weigh as much as 4 kilogram each kidney. This is big weight. But the cyst, do the air-filled cyst gives us weight? No, it is not the air-filled cyst. These are the liquid-filled cysts. They are large, and all the cysts are filled with serous fluid. Uh, that is why weight of the kidney is so large. The external surface is composed of masses of cysts that are 3 to 4 centimeter in diameter. And then there is no intervening parenchyma. All what you see is just the cyst in the kidney. There is no intervening parenchyma. The parenchyma gets lost. Reveals function of nephrons dispersed between the cysts. Cyst may be filled with serous, clear fluid with turbid to red brown, sometimes hemorrhagic fluid. There may be some hemorrhagic component in the fluid, but otherwise it is a serous fluid. The cysts are large and encroach on calyces, pelvis to produce pressure defects. So these cysts are so large that you hardly ever see any parenchyma. And since they are very large, they put pressure on the normal tissue and there is nothing normal left. Large and they encroach on the calyces and pelvis to produce pressure defects. You can see the pelvis getting compressed. The calyces and pelvis gets compressed there. This is what you see on the microscopy. You see thin epithelial lining. At places, it may be columnar to cuboidal. but you see cyst everywhere. If there is any normal tissue left, you can know by that normal tissue that it is kidney on microscopy, right? If the whole picture is just cystic and there is no normal tissue, so unless someone tells you it's kidney section, it is not possible to know. If there is some normal structures there, like kidney tubules and glomeruli, you can easily say it's a kidney cyst, renal cyst, right? Cysts arise from tubules throughout the nephron, therefore they have variable epithelial lining. Occasionally, papillary epithelial formations and projections into the lumen may occur. Right, so this kidney has got some normal structures left in there. So this is kidney cyst, again renal cyst, that has got variable lining epithelia, and occasional papilla formation is there, right? Occasional papilla formation may be there. All right, I can go behind here. There you can see protrusion of structures inside of the cyst. Here it is trying to form papilla. Look at the papilla, right? This is the papillary structure, sort of, and the rest of this is okay. This is just a division between the two cysts, but this is a papillary structure. So it can give rise to papillary projections into the lumen. These are glomeruli, don't confuse those with the papilla. And this is Bowman's capsule getting cystic changes. So Bowman's capsules are occasionally involved in the cyst formation. Glomerular tuft may be seen within the cystic spaces. You can see the glomerular tuft there. This is glomerular cyst, right? This is another cyst, and look at the compressed epithelium. This is possibly cuboidal or columnar epithelium that has become compressed to look like a single layer of compressed epithelium. Clinical features are pain in the renal area, then there is dragging sensation, and progressive chronic kidney disease, which means it will eventually, it is going towards renal failure. And it could, the patient may throw blood clots, right? The patient may throw blood clots and have renal colic. All colicky pains come and go. That is what is colic. There's severe pain that is got in between some resting time period when there is no pain, and then there is severe pain again. And what happens is there is patient keeps throwing lot of blood clots. Polycystic kidney disease. Two mutations are there. Older age of onset, that the later patient undergoes renal failure, and progression is accelerated in males, in blacks, in hypertension. Somehow these blacks have got greater tendency, or their genetic makeup is such that they are more prone to the disease. There's nothing else is special. So what are the extrarenal congenital anomalies accompany that? Polycystic liver disease, intracranial berry aneurysms, mitral valve prolapse, cardiac valvular abnormalities are there, right? So liver disease is there. In the brain, there are berry aneurysms, then there are mitral valve, then there is mitral valve prolapse, and then there is cardiac valvular abnormalities. Mitral valve, and there are other cardiac valvular abnormalities. Other than that, liver and brain are involved in polycystic kidney disease type 1, or adulthood polycystic kidney disease, right? Autosomal recessive or polycystic kidney disease of the childhood. Polycystic disease of the childhood is autosomal recessive, and it is because of abnormality of the gene polycystic kidney disease type 1 gene, and that encodes for the protein fibrocystine. When do you see the abnormalities? In the perinatal period. Perinatal period is 1 week. It exists up to 1 week after birth and begins in the utero, but it exists 1 week after birth. then you can see these diseases or diagnose these diseases up to 1 month after birth. That is neonates, infantile 1 year after birth, and juvenile in the puberty onset people. Kidneys become large again, but they don't have bubbly outer surface. They have smooth external surface. There is no external cyst. There is no external renal cyst. Kidneys are large, but they don't have external kidney cyst. The kidney, look at this smooth kidney and look at the cross section of the kidney. The cysts lie at a right angle to the external surface. They're longitudinal cysts and they're lying at a right angle to the external surface of the cortex. And this is just by looking at the kidney, you could diagnose polycystic kidney disease type 2. You can say childhood polycystic kidney disease could be diagnosed just by looking at the kidney. It is the age of the patient, and just by looking at the kidney, you could diagnose type of kidney disease. Cross section, numerous small cysts in the cortex are there, and medulla may be present, and this gives appearance of a spongy kidney. Longitudinal cysts in the cortex, and there are some round cysts in the medulla as well, and this gives rise to appearance of sponge-like appearance. Dilated, elongated channels are present at right angle to the cortical surface, and they completely replace the medulla and cortex. You can see those renal cysts, they completely replace the medulla and the cortex. Cylindrical or secular dilatation of all the collecting tubules. Cylindrical or secular dilatation of all the renal tubules is there. Cysts have a uniform lining of cuboidal cells collecting ducts. Liver has got portal fibrosis and proliferation of portal bile ducts. Cysts have uniform lining of cuboidal cells. You agree with that? Yes, we will just see micrograph in a moment, and we will see that cysts have got cuboidal cell lining. So that is another difference between adult type of polycystic kidney disease and the childhood type of polycystic kidney disease. Adult had flattened epithelial lining, and they have portal fibrosis, proliferation of portal bile ducts that will give rise to cirrhosis in the end. So just look at this kidney, longitudinal cyst that lie parallel to the cortex, and then there are rounded cysts in the medulla here. And this is what the microscopic picture looks like. The cysts are lined by epithelia that have cuboidal appearance, cuboidal to columnar appearance. Amna Pervez, if you have any query, please type in the chat box. Infantile and juvenile forms of the hepatic fibrosis, we have discussed that, and proliferation of well-differentiated biliary ductules is a condition termed as congenital hepatic fibrosis, right? So along with the cystic kidney, there is congenital hepatic fibrosis, that is the extrarenal manifestation. Now we come to the cyst of renal medulla. In the medulla, we have two kinds of renal cyst, rather three types: medullary sponge kidney and nephrotheuses are the two topics we are going to discuss together. Adult onset medullary cystic kidney is the third type of renal cyst there. Adult onset medullary cystic kidney or medullary sponge kidney, they have similarities. Adult onset medullary sponge kidney, they're almost similar. So we have in this kind of medullary sponge kidney or nephrotheuses, we have abnormalities in the cilia, and there is fibrosis in the interstitium. So there is abnormality in the function of the nephrons, and then there is problem with the fibrosis in the interstitium. So The renal function is severely compromised, is badly compromised. Multicystic kidney dilatations are there in the medulla. It occurs in the adults. Calcification are there in the dilated ducts. There's hematuria, infections, urinary calculi are there, and renal function, however, is usually normal, is usually not normal. Just look at the cyst, look at the cortex. Now, if the cortex is largely spared, if the cortex is largely spared, we may have renal function that is normal. The renal function can be normal if the cyst do not cause compression and atrophy of the cortex. On gross papillary ducts are in the medulla, they are dilated. The papillary ducts get dilated. However, there are some normal ducts as well, but mostly they are dilated. Small cysts may be present. Cysts are lined by cuboidal or transitional epithelium because the papillary ducts have transitional epithelium in the later part, so they may be lined by the transitional epithelium. Cortical scarring is absent, so it means that cortex is spared. Cortex is spared unless there are such large cysts that they will put pressure in, they will cause pressure atrophy. If there is no pressure atrophy, cortex is spared. So look at these cysts. They are lined by, these are cuboidal cells. Cuboidal cells here and here and here. These are all cuboidal cells, right? Look at this, is a very pretty line of cuboidal cells. But here we do see some compressed epithelium as well. So seeing the cuboidal cell is not hard and fast rule. It is not necessary that you will always see cuboidal cells and be able to appreciate. There may be some compressed epithelium among the normal cuboidal cells, and at places you may find transitional epithelium as well. All right. Cysts are concentrated at corticomedullary junction. Now we come to nephrotheuses or medullary cystic kidney. Nephrotheuses or medullary cystic kidney, the cysts are concentrated at corticomedullary junction, and injuries to distal tubule, tubular basement membrane disruption, and chronic and progressive tubular atrophy involving both medulla and cortex, and interstitial fibrosis is there. Corticulotubulo-interstitial damage is the cause of eventual renal insufficiency. Damage in the interstitium and damage to the tubules, fibrosis is there. This is the renal cyst you see in the medulla. If cortex is spared, all the better, but cortex is usually not spared. Chronic and progressive tubular atrophy involving both medulla and cortex. If both are involved and there is fibrosis, it is not spared. So, do you like this kidney? Inside the cyst is hemorrhagic fluid. So they look dark and chocolate colored, and they are called as either it is nephrotheuses or it is the renal medullary cyst. If it is renal medullary cyst, it is autosomal dominant condition. But if it is nephrotheuses, it is autosomal recessive condition. Sporadic, non-familial, familial, juvenile nephrotheusis, and renal retinal dysplasia is extrarenal manifestation. Small contracted granular surface. Until now, we have studying large kidneys, but these kidneys are small, and corticomedullary junction is involved. Cuboidal or flattened epithelium may be there, surrounded by either inflammatory cells or fibrous tissue. Right, so it is corticomedullary junction basically that gets involved, and then you can see fibrosis there. This is what is the micrograph. This is how it looks. So look at the compressed epithelium because it is a very large cyst, and you can see some normal cuboidal epithelium as well. Widespread atrophy is there, thickening of the basement membrane of proximal and distal tubule, interstitial fibrosis is there, glomerular structure is preserved, right? Widespread atrophy because of the large cyst, there has to be widespread atrophy, and thickening of the basement membrane of proximal and distal tubules, right? Interstitial fibrosis is there. So there is fibrosis here, tubular atrophy and fibrosis. Glomerulus is preserved. There is polyuria and polydipsia. Until now, in all glomerular diseases, we have studied uh, oliguria. Now comes in the term polyuria and polydipsia. Whenever there is increased urination, it is accompanied by increased thirst. And that is what is polydipsia, increased thirst. Polyuria is urine more than 3 liters a day. And that polyuria has got a lot of salt wasting because abnormal tubular function, there is salt wasting and tubular acidosis. Extrarenal manifestation, we talked about retinal atrophy before, and there are oculomotor abnormalities, abnormalities. And please do remember, when we talk of extrarenal problems, we will definitely get also problems of salt wasting or sodium wasting. Liver fibrosis, since there was interstitial fibrosis, there is fibrosis elsewhere as well, and that is liver. Liver undergoes fibrosis. There may be cerebellar abnormalities, right? Cerebellar abnormalities, the balance is not well kept. Dialysis associated renal cyst. What happens in the dialysis? Cyst everywhere. This is what happens. Cyst everywhere, and the kidney is small and contracted. Numerous cortical and medullary cysts. Now there is no liking for any area. If it is iatrogenic or self-induced kidney injury, it does not respect any place. It just involves cortex and medulla equally. Numerous cortical and medullary cysts are there. So cysts are 0.5 to 2 centimeters in diameter, and they are filled with serous fluid, clear fluid. Hyperplastic or flattened tubular epithelium. So you can see the flattened epithelium, or it may have undergone hyperplasia as well. And calcium oxalate crystals means there is a tendency to have stones in these cysts. Obstruction of tubules by interstitial fibrosis or by calcium oxalate crystals. So there is risk of renal cell carcinoma. RCC stands for renal cell carcinoma. And these cysts can even have malignancy, right? So dialysis associated cysts involve cortex and medulla. They could be small, like 0.2 centimeters, or even big, are not very big, 2 centimeters. However, they're filled up with clear fluid. They can have calcium oxalate crystals and even stones. Their lining epithelium is hyperplastic or flattened, and they cause obstruction of tubules by fibrosis. So you could see contracted kidney with lot of cysts everywhere. Simple cysts are just an incidental finding. Mostly they're incidental finding unless they cause some renal disturbance, like sometimes they are the place where stones are formed. They could be multiple or single. Multiple is a problem, but single doesn't matter. Usually cortical cysts spares that vary, usually cortical cyst spaces that vary widely in diameter. So Simple cyst can be a small simple cyst. Simple cyst can be a very large simple cyst. And as long as it is single and it is not complicating anything, they are they don't do much harm. Translucent, lined by gray glistening smooth membrane and are filled with clear fluid. Single layer of cuboidal or flattened epithelium may be present, or they may be completely trophic, like flattened epithelium, trophied flattened epithelium may be there. This is just simple cyst, one single cyst, which is large, and it lies near the cortical surface. So we come to the end of cyst, renal cyst. Please keep this diagram pasted in your book so you will know what simple cysts look like, what recessive polycystic kidney is like, what autosomal dominant or adult onset polycystic kidney is like. Recessive polycystic kidney is childhood polykidney disease that has PKD1 defect, and it has got a perpendicular cyst. The other dominant polycystic kidney disease is adult onset polycystic kidney that has got multiple cyst, large cyst, and the kidney is large and may have a very huge weight as well. The dialysis kidney is a contracted kidney with cyst everywhere, right? It has cyst everywhere. It is prone to renal cell carcinoma, and it may have calcium stones or calcium oxalate crystals there. Medullary uremic kidney. Medullary kidney is in the medulla alone. Cyst in the medullary cystic kidney, there are cysts in the medulla alone. In the medullary sponge kidney, there cortex and the medulla both may be involved. They may be involved, but there is fibrosis in the interstitium, and there could be fibrosis in the lung, in the liver as well. So if there is fibrosis in the liver, you must look for, once you have discovered kidney disease, you must look for the liver disease as well. In the dysplastic kidney disease, there is, along with the cyst, you may see dysplastic epithelium, like dysplastic connective tissues, things like cartilage, bones, and muscles, and you could see anything that comes out of the connective tissue, primitive connective tissue there. So you have cyst along with the abnormal, uh, abnormal formation of structures. Hydronephrosis. In hydronephrosis, you have to distinguish it from the cystic diseases because there is very large collecting system. The collecting system is not cystic. This is not cyst. This is just a large collecting system, and and a large kidney, right? It's a large kidney and large collecting system. You don't have to uh, confuse this disease with the cystic kidney disease. So you just keep your kidney very safe, because we don't like dialysis either. We don't like dialysis. And if there is a renal disease, just discover it early, it is better. We will come to another entity, tubulointerstitial nephritis. Tubulointerstitial nephritis means that there is inflammation in the interstitial part, and this interstitial part nephritis may be because of infection, it may not be because of infection, right? Nephritis or inflammation is not always because of infection. Predominantly involves tubules and interstitium. No glomerulus or the glomerular apparatus or the Bowman's capsule, they are all spared. So tubulointerstitial, as the name suggests, it involves tubules and tubulointerstitial interstitium. Tubules interstitium. Inflammation is sudden in onset, and there is azotemia, which means there is increased BUN and other toxic substances, but they are not clinically evident. There is no uremia. In acute form, there will be neutrophil. In the interstitium and tubules, you can see neutrophils. You may see eosinophils, and there is edema. All these three features. But in chronic form, there is fibrosis. atrophy of the tubules. If it becomes chronic, there will be fibrosis, atrophy of chronic tubules. Now the infiltrate is mononuclear leukocytes. Prominent fibrosis, you've just done that. Widespread atrophy, right? There is widespread tubular atrophy. And how will you distinguish glomerular diseases from the tubulointerstitial nephritis? There will be no syndrome. Nephritic or nephrotic, there will be no syndrome, right? No nephritic or nephrotic syndrome, and there is defect in the tubular function. So how we will know the defect of tubular function? Let's see. And the defect in tubular function may be minor or major, and that impairs, there is tubular defect in inability to concentrate urine. Inability to concentrate urine, evidenced by polyuria or nocturia, right? Salt wasting, diminished ability to excrete acids, metabolic acidosis. If there is no excretion of the acids, what will happen? Have you seen a kidney patient having rapid acidotic breathing, deep acidotic breathing? That is because of the renal function by the tubules and interstitium is not normal. So there is no normal excretion of the acids. Isolated defects of tubular reabsorption or secretion, like there may be some isolated defect of calcium abnormality, or reabsorption of substances may be impaired. Advanced forms, however, may be difficult to distinguish clinically from other causes of renal insufficiency. Once the kidney disease is advanced, like it has undergone chronic renal failure. Failure is always a failure. Now it becomes very difficult to know what was the cause of their failure, because everything in the kidney goes haywire. So this is one whole slide that is very busy, and it shows you all the things we have done, like nephrotic and nephritic syndrome are absent. There is no tubular functions are abnormal. What is abnormal tubular function? There will be increase in urine more than 3 liters per day. Salt wasting is there, and there is inability of the kidney to excrete the acids. And because of that, there is acidosis in the body. What is normal pH in the blood? What is normal pH in the blood? Anything when the normal pH decreases, then we have acidosis. Normal pH, please type quickly, don't search the net. 7.4. Infections. Right, so interstitial nephritis or pyelonephritis would be because of acute bacterial pyelonephritis. The infections can come from down there, right? From the collecting system. Chronic pyelonephritis, acute or chronic, they can both cause interstitial and tubular infections. And viruses, parasites, yes, Wasim Zedi, Ali Zedi, and Wasim Zedi. All what you're typing is names either. Well, never mind. All right. Other infections are viruses and parasites, no matter whatever causes nephritis. It could be bacteria, acute, chronic, virus, parasite, and those could have come from the collecting system. Toxins, yes. What toxins can cause interstitial nephritis? It could be drugs, and drugs, analgesics. Drugs, analgesics are very notorious. It takes around 3 years to cause renal failure, but before that, it can cause abnormal renal functions, right? No, you don't need to on your cameras. My students and I don't need to on my camera. We are only involved in serious study, not looking around. That is one advantage in sitting at home. Student who wants to concentrate and study can study. Right. Analgesics, heavy metals, and lead and cadmium. See, heavy metals, lead and cadmium, all of them cause kidney damage. Metabolic diseases. In metabolic diseases, we have urate nephropathy, nephrocalcinosis, and we have hypokalemic nephropathy and oxalate nephropathy. Physical factors: chronic urinary tract obstruction, neoplasias like multiple myeloma. What goes wrong in multiple myeloma? If you could answer quickly, what goes wrong in multiple myeloma? Light chain cast nephropathy. The light chain in multiple myeloma is a tumor of the plasma cells. And a lot of light chains, abnormal light chains, circulate in the blood. They settle in the kidney and they cause interstitial nephritis and they cause tubular nephritis. Immunological reactions, transplant rejection, Sjogren's syndrome, and sarcoidosis. And then we have vascular diseases and we have miscellaneous diseases. Right. It could be idiopathic as well, right? It could be unknown causes. But unknown causes are after including all the known causes. Urinary tract obstruction uropathy. Is that a common disease? Aisha, do you have a problem? Aisha Sadaf, do you have a problem? You could type yes or wrong, or no if you don't have a problem. If you do understand what I'm teaching, then it's good. Don't, no, 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 no. No one needs to on their camera. Please don't do that because you get busy, really busy in self-chatting, and later, literally, when you open your book, you will have problem in understanding things and reading things. Please do concentrate. Whenever I used to open my book, even though sometimes at times I did not have time to read the lecture, but when I used to open a book, it was always that some words of my teacher rang bell, and at that point, it was very easy to come out of a difficult thing. Urinary tract obstruction is a very common entity. Almost every student is aware of that. You might have seen your relatives or some people even in the hospital suffering from renal colics, right? And what this problem can do to the kidney, we'll just read the entire stuff or discuss the entire stuff. So obstructive uropathy and hydronephrosis, this is what it could do. It could, because of obstruction, it could cause hydronephrosis. Hydronephrosis is a large kidney that has a large collecting system and atrophied cortex. Atrophied cortex will, what will atrophic cortex do? It will destroy the parenchyma. It will destroy the functioning unit of the kidney. What is the functioning unit? It is the nephron, right? So it can eventually make the kidney fall into that rubbish bag or into the dustbin of chronic renal failure. There is increased susceptibility to infection and to stone formation. If there is obstruction, obstruction could be external or internal, right? A pressure from external surface on the ureter from exterior or any organ that has undergone a pathology of tumor formation of or any other pathology could obstruct the ureter from outside or could obstruct the collecting system from outside. And that just keep this one thing in mind. Anything that is standing, like fluid that is not moving, it is standing, may create a problem. So increased susceptibility to infection is there, one problem. Then to stone formation is there, because it is a salt-rich solution, so stones can form. Renal atrophy, unrelieved renal obstruction the kidney can undergo renal atrophy. Surgically correctable or medically treatable, yes, they are. If you remove the obstruction, you cure the patient, you cure the person. And of course it could be slow in onset, or it could be sudden, because a stone is sometimes formed in one of the renal calyces, and then it goes to a narrow passage of ureter and gets stuck there and cause renal tract obstruction. Obstructive uropathy, partial or complete obstruction is there. Unilateral or bilateral obstruction is there, right? Any level of urinary tract from urethra to the renal pelvis gets blocked, or any level from the renal pelvis, any level of urinary tract from urethra to the renal pelvis is there, or intrinsic or extrinsic lesion may be there. I think admin is typing for you. They want to know if you're present or you're absent. All right, well, that is another problem. Slav Papilla, I think you will soon have your colleges open, as the HEC is discussing to open the colleges and schools and everything, maybe from 15th of July, maybe. Just so let's see. Causes Slav Papilla or blood clots are there. Pregnancy, right? Papilla can block the collecting system, and pregnancy can do the same. Uterine prolapse or cystocele. Functional disorders, neurogenic spinal cord damage or diabetic nephropathy, and then there is dysfunctional. Dysfunctional obstruction. If there is spinal cord damage, then there is problem with the sympathetic and parasympathetic nervous system, controlling urinary release and retention and all that. That will cause abnormal dilatation of the ureter, back pressure, and cause nephritis. The dysfunctional obstruction could be there. Congenital, posterior urethral valves and urethral strictures. Posterior urethral valve and urethral strictures. Urethral strictures you are very much familiar with. Posterior urethral valves may be abnormal, and in this case, I will say that you had undergone a case study in your lecture theatre where there was absent posterior urethral valve. This problem is difficult to diagnose. Meatal stenosis is there. Then bladder neck obstruction can be there. Utropelvic junction narrowing or obstruction is there. Then there is severe vesico-ureteral reflux, right? Severe vesico-ureteral reflux. Because of abnormal valves in there, there is severe vesico-ureteral reflux, or there could be abnormal in nerve innervation, neurogenic problems, because of which there could be vesico-ureteral reflux, right? And this reflux will damage the kidney. Hydronephrosis, dilatation of the renal pelvis and calyces, which is the collecting system of the kidney, pelvis and calyces, associated with progressive atrophy of the kidney due to obstruction of the outflow of the urine. So if there is dilatation of renal pelvis and calyces, there will be atrophy of the kidney because of back pressure on the cortex and medulla. There is atrophy of the kidney, and that will cause some problem in the renal function. Obstruction triggers an interstitial inflammatory reaction leading to interstitial fibrosis. There is fibrosis in the interstitium. Obstruction triggers interstitial inflammatory reaction, and that will cause some kind of fibrosis there as well. Early cases, slightly to massively enlarged kidneys, significant infiltrate or inflammation is there. In chronic cases, what do you expect? In chronic cases, you expect fibrosis. You expect atrophy and fibrosis and blunting of pelvis apices of the pyramids. No, I want to show you a diagram of the same. Blunting of the apices of the pyramids. I hope there is. Yes, here it is. Those are blunted. Those are blunted, right? Apices of the pyramids. There are no apices of the pyramids here. They're all blunted because of the collecting system. Hypertrophy, or you can say because of the dilatation of the collecting system, the apices are blunted, renal cortex is atrophied, and even the medulla is atrophied. So all what you see is cystic spaces, which are not cystic, they are dilated collecting system, right? In far advanced stages, there are thin-walled cystic structure, 15 to 20 centimeter in diameter, which is a big, huge diameter. 20 centimeter diameter is a large diameter. And then there is parenchymal atrophy. There is total obliteration of the pyramids, and there is thinning of the cortex. Clinical features: acute obstruction, there is pain, calculi, renal colic is there. Oh, those features are there for almost all the nephritic and interstitial diseases, tubular interstitial diseases, right? Pain, colic, and in some diseases there is hematuria, particularly in, or there may be pyuria, particularly in, या कोई जवाब तो दे दिया करो जल्दी से. Cancer, renal malignancies में, this is a very common feature. Renal colic, pain, there is even a mass, and then there is hematuria. And then you can see hematuria in so many other diseases. Hematuria of tubular onset and of glomerular diseases have to be differentiated. Okay? By the end of this lecture, if I have time, I will try to discuss that. Prostatic enlargement may give rise to bladder symptoms, and then there is unilateral, complete, or partial hydronephrosis, silent. When the hydronephrosis silently kills the kidney, it is asymptomatic, and when discovered, kidneys are near to fail. Kidneys are nearly failing. So there is intravenous, you do intravenous pylography first, and that gives you the first indication that things have really gone bad. In the first few weeks, you relieve the obstruction, everything comes back to normal. You miss the first few weeks, things become bad. You may lose some kidney function forever. Ultrasonography, non-invasive techniques are diagnostic because we, all of us, like no injections. We don't like any invasive techniques. So non-invasive techniques for every disease is done first. And that includes ultrasounds and so many other radiological investigations. Bilateral partial obstruction, inability to concentrate urine, pyuria and nocturia, distal tubular acidosis may be there, salt wasting, secondary renal calculi, chronic tubular interstitial nephritis, scarring and atrophy of the papilla and medulla, and then there could be hypertension. The hypertension comes in the end because after causing so many abnormalities, the kidney might detect low pressure and it may cause hypertension. False detection of low blood pressure and hypertension may be there. Oliguria or anuria, complete bilateral obstruction, that will cause oliguria. Incompatible with survival unless obstruction is relieved. post-obstructive diuresis after relief, massive with kidney excreting large amounts of urine that is rich in sodium. I think lecture today was not so difficult, but anyhow, if there are any problems, please let me know. All right, bye for now. Thank you very much for being a patient listener. And I appreciate all my students. And some of them I appreciate a lot for coming early, like Wasim and so many others. They are always very early to come in the to join the class. They at least join half an hour to 15 minutes before. All right, thank you and Allah Hafiz.